Hello. Welcome everyone to this afternoon keynote presentation by Dr. Peter Newman. Dr. Newman is a professor at the Factor Inward Touch Faculty of Social Work, University of Toronto, and an affiliate of the Joint Center for Bioethics. He has been recognized with an Early Researcher Award by the Ministry of Research and Innovation, Ontario, the RBC Chair in Applied Social Work Research, a Canada Researcher in Health and Social Justice, and was an inaugural fellow of the Society for Social Work and Research. His global research program is at the intersection of social science and biomedicine and the LGBTQ+ health and human rights issues. He has been continuously funded over the years by the Tri-Council funding organizations. And Newman is a co-founder of Voices Thailand Foundation with an extensive consulting experiences for the United Nations on issues related to HIV/AIDS. And Dr. Newman is going to talk to us about the intersecting pandemics and a tale of two vaccines, from technocratic reductionism to a biosocial approach. Dr. Newman, take it from there.
Thank you. Thank you so much, Dr. Lugana, for your introduction and for reading through the hard titles and all that, so I don't have to. I want to really thank the conference organizers for having me and co-chairs. I mean, it's a pleasure to be here with you today. By way of a slightly less formal introduction, I just wanted to situate myself a bit. I'm a professor of social work. It will come up later in terms of discipline. So I mean, my own disciplinary training is interdisciplinary in social work and social psychology. But I also started as a frontline social worker at the San Francisco General Hospital outpatient AIDS clinic in the beginning of the 1990s, when the first ARV AZT had just recently become available. So, I mean, that's probably the largest part of my motivation of that I'm, here in terms of doing research. It was obviously an extremely trying time. I do want to recall so that there was like a small physician room, and it was a very large public hospital, and it was certainly an anomaly of the US public health system that it was a clinic that would serve indigent patients, people that couldn't pay because they were supported by the state. But we had some of the star doctors of the early part of the HIV epidemic, several of whom are still, with us. And it was, so I mean, it was a very powerful impetus for me. Frankly, part of it was out of seeing researchers come through the clinic and seeing that maybe I could make an impact. But another definite part of it was trying to see that I would avoid burnout. And as the patients coming into the clinic started to be younger and younger than myself, fresh out of graduate school, I realized I had to try to transition after 5 years there to keep going. So I really do honor all people who are working with people living with HIV over the past many decades. The primary point I want to make today is the need for really a seismic shift in approaches to HIV and thinking about HIV. And I imagine that many people in this seminar may be on board with this already. But the notion is from the valorization really of biomedicine and social science is always playing some sort of background contextual role to really turning the paradigm upside down, or as I really would mean to say, right side up. And that all biomedicine and disease is mediated through social, cultural, historical, and structural factors. So as everyone who's been reading and seeing things through the news, seeing things through professional journals over the past year, there's been many analyses looking at implications of the HIV response to approaches to the COVID-19 pandemic. In general, I think it's not difficult to say that I think that a lot of the lessons that were more carried forward were some of those as part of biomedicine, and less so the lessons that we should have learned from social cultural aspects of the HIV pandemic. And of course, those challenges still are ongoing in terms of HIV. I mean, certainly one of those very concretely is the decades of research that have went into planning, trying to develop HIV vaccines, which happily jettisoned the search and development of a vaccine for COVID-19. You know, but as I said, that some of the other aspects of our response to COVID certainly strongly reflect the fact that there's still quite insufficient attention to the social structural conditions that produce disease and produce vulnerability. So this piece was written by a pretty well-known public health prof in the US, Lisa Boleg. We're not all in this together. And she was responding to kind of many sort of easy commentaries that were kind of flowing in, that as COVID is the great equalizer. And, you know, we're all suffering, and, you know, to some extent that's true. I mean, it impacts all of humanity. But there were very different, obviously, forms of suffering and forms of people, the haves and have-nots in terms of access. And really, just like HIV before it, in a somewhat different way, as Jonathan Mann said years and years ago in terms of HIV, that HIV was somewhat of a litmus test to show the fault lines that run through society in terms of many kinds of disparities and adverse social determinants of health. And we see this again with COVID. So for today, I want to speak to more broadly a biosocial approach and what that entails. And then I'm going to talk about an intervention that I led and worked with for the past year in terms of dealing with the response to COVID-19 among marginalized communities. I'm going to focus on the Toronto site, but that project also is still occurring. The intervention's finished in Mumbai and in Bangkok. I'll talk a little bit about a related project on vaccines. And with those projects, I will at least draw on my understanding of how that kind of foregrounds or speaks to some of the aspects of a biosocial approach to dealing with COVID-19 and also to HIV. So I won't go into this like step by step, but you know, the major aspect of a biosocial approach is that it's not like social forms of context in which biomedical and biological phenomena are expressed. They're mutually constitutive. And really, from my understanding, the most important aspect of a biosocial approach is a shift. It's like a paradigmatic shift in the way we think about and respond to disease, to human conditions such as HIV and COVID. Again, getting out of the picture that, well, social aspects, historical aspects are certainly very important as context to understand the real issues that are going on in terms of biomedical phenomena. I will certainly credit these authors here for this diagram, which helps to kind of a little bit situate it in terms of what a biosocial approach, how we might kind of map that. And the main part of this that I think is important is that, so rather than here at the core of this situating disease, so situating HIV or COVID. It's situating psychosocial conditions that produce vulnerability to COVID. And so it's quite a different focus than what we often see, which is that the individual would be at the center of this model. And so that all things then become mediated through individual agency and individual choice. Syndemics are actually a sister and to some extent daughter of biosocial approaches. So a syndemic approach is biosocial in its nature. But some things that are a little bit different in terms of, and not as well represented here, is that understanding the challenges in the response to both HIV and COVID is the concept of marginalization. And so that marginalization is both a set of structural factors, but it's also ongoing processes and ideologies that produce structural and systemic inequality. So things like racism, sexism, homophobia, transphobia are some of the factors that are driving marginalization, and that some of what gave rise to our Safe Hands, Safe Hearts intervention. One other aspect that emerged in terms of discussions of a biosocial approach is the notion of transdisciplinary. And so, I mean, I think we've all heard that in various ways. And as I'm understanding it, first of all, multiple disciplines were involved in germinating a biosocial approach, but that what's different than multidisciplinarity or interdisciplinary is that rather than kind of getting all of these great minds from different disciplines together to kind of think and co-think about how we might approach challenges, let's say of HIV and prevention, it's actually the disciplines get together, but it's creating a new vision and a new methodology based on the social condition of HIV. So it's not merely distilling the phenomenon of HIV or COVID-19 through a disciplinary lens. I'll show, I have a picture of that to the extent that can help. So biosocial response approach is a response to this, and certainly Paul Farmer was a very big part of discussing this, writing about it, in terms of privileging what's inside the body. And then as much as there's an appreciation, of course, for social structural conditions that produce vulnerability, ultimately, biological sciences privilege what happens inside. That's what's real. That's what we can actually measure. And the idea is to isolate and to get as close as possible to specifying and measuring very specific factors. And that's how we can know what's the root of disease and also what's involved in a response and a cure. And that same form of reductionism is, of course, the focus of clinical trials. And that we want to, it's like a laser focus on efficacy of a product, but these other things are kind of seen more as noise. I mean, that's been gradually changing quite a bit over the past couple of decades. But there's still this notion of this is the pinnacle. So this was some early work that I did with collaborators in South Africa and India. In terms of, I wrote this piece, which, you know, it was a short piece, but I think I probably spent more time writing it than many of the things I've written, that was kind of critiquing this kind of ex post facto response to clinical trials, some of which went bust in terms of vaccines, in terms of some medications in various low and middle income countries. And just the core of it was just suggesting that we spend some more time and money and have some more investment in terms of looking at the social and community factors around clinical trials so that we wouldn't be shocked that a trial, for example, in this case, was shut down in Cambodia by the king of Cambodia because there was an upsurge of protests from a variety of community stakeholders. And the researchers really didn't, I mean, they were doing what they thought was their level-headed best and didn't understand why these, what happened. And there was really a lack of attention to stakeholder engagement. I have to be honest on that. In part, I also meant this as somewhat tongue-in-cheek. I don't think it was read that way, which is that you can't do a science of community engagement in the same way that you do a science of drug discovery. But to some extent, as I and others too, were kind of throwing down the gauntlet to pay more attention to these social conditions, aspects of involving communities, and how to do that, looking at various factors, how to do that systematically, not just like a trial and error approach and then see what happens and what blows up. So that we did a study trying to actually implement it, as many other folks did. And, so these are some of the issues, it looks like you just want them when the going gets rough. It's like qualitative research with people who had participated in early HIV vaccine trials and biomedical prevention trials who, some of whom had some things to say about how they felt what they saw as their role and how they were treated in those trials. And also the notion of that often very well-meaning researchers and some really good products came out of some of this research, but there was always the notion of, and I think it continues, mostly it's rich, high-income Western countries that are providing the money and the organization of many of these trials. And there's no malice on the part of investigators. People are doing as much as they can and have an earnest investment in, let's say, moving forward in terms of responses still to HIV, and even now in terms of research on an HIV cure. But in the background was always this notion that somehow we had to deal with culture as a challenge. So we had to move into some of these low-income, middle-income countries on other continents and figure out how to kind of work with their challenging cultural systems and norms. And so what we tried to suggest in this kind of overview was that, of an attempt to kind of decenter that a bit, and also to understand culture as an asset. And how would we understand what are the strengths in a particular place, understanding there are challenges in terms of honoring how people best understand information about clinical trials, how to find out who to work with and how to build trust. And they're certainly now reflected in the work of AIDS Vaccine Advocacy Coalition is really moving very strongly on this, the International AIDS Vaccine Initiative as well. But still, as COVID rolled out, and this is not necessarily owned only by biomedical researchers. I mean, to some extent, I believe we all share in this hope and this fantasy of a magic bullet, and that somehow we're going to find the right cure or the right vaccine, and okay, the problem will largely be, will be over, will be dealt with. And of course, after 4 decades into the AIDS epidemic, I think we've learned that, well, certainly there's been massive movement forward in terms of moving towards a chronic health condition among people who have access to treatment and healthcare and medicine. But it's of course not evenly distributed, and it's by no means magic. So back to briefly biosocial approach in terms of some of the work of Paul Farmer specifically. As you can see here, that disciplinary approaches, frankly, can have a lot to offer, and we can have a lot to offer if we work together. But it's when people become, and myself as well, when we become sort of limited or blinded by our own disciplinary understanding, favored theories and methodologies, that we kind of lose sight. So this is what I was talking about in terms of this transdisciplinary model, where it's actually not just how the lenses of these different disciplines are aligned to address, let's say, COVID-19, but it's actually reformulating methods from multiple disciplines that are grounded in responding to the so-called problem or challenge. And that's really a somewhat different paradigm and different approach. One thing I really like, and I just want to finally put this out there in terms of what Farmer talked about, was, of course, on the one hand, this biomedical reductionism, but very importantly, and this certainly is important for me in terms of my approach and my understanding and my ability to collaborate with people across the spectrum, is that it's not only biomedical researchers, it's not only physicians who become disciplined in the way they're thinking and foreground their own theories, methods as being sacrosanct and most important, but this happens in many fields. And so that to some extent, we all can be bound up, because my point with this is certainly not to say throw out biomedicine. I mean, my God, that would be crazy. I mean, in terms of dealing with HIV and prevention, but it's understanding how disciplinary lenses to some extent divide us and prevent us from kind of thinking anew and collaborating in a more serious and realistic way that responds to problems, rather than distilling our understanding through disciplinary training. Another strand of this that I'll just briefly mention is, of course, underlying this kind of reductionism is this notion that people are individual actors who make decisions. And, that moves on and on into the, so that, to more thorny problems. Well, people can choose to use condoms. They can choose to take PrEP, so that you kind of throw out the structural conditions that underlie the totally lower rates of PrEP use among many marginalized communities in Canada and the US, as if it's an individual issue, and similarly, large issues around COVID vaccination. So I thought this depiction was really great. And the notion of just kind of encapsulating a biomedical lens, right? The focus is here. What Farmer would also refer to as like downstream factors. And the idea is to isolate, to get to the actual quote unquote cause and some of the immediate behaviors which kind of cause potentially disease. But what's important is so that through this lens, it might be very good at dealing with some of these very proximal issues, but that this biomedical lens is fundamentally incapable. I mean, it really is fundamentally incapable of dealing with and looking at these factors as anything else besides some kind of context or background that sometimes we can honor as important, but it really can't handle studying them because you can't reduce these things in the same way. So, in the words of this Dr. Eugene Richardson, who is, I mean, this is probably a little stronger than I would put it, but I thought it was very interesting. And I imagine that some, more critical social science researchers here certainly, entertain this notion of that, it's almost that sometimes science is used, it may not be purely intentional, as a way of maintaining the status quo, so that under the guise of scientific inquiry, when we make things individual level problems, of course, you don't need to really look at seriously structural change in which you might actually have to give up something, and you might have to look at your own role in promoting the status quo. So now I'm going to shift to talking about this intervention that we developed with a team of people, as I mentioned, so in Toronto, Mumbai, and Bangkok primarily, to deal with what we saw certainly happening before us in terms of particularly sexual and gender minorities, and in the Canadian context, certainly in the US context as well, racialized populations amid COVID. So this was actually some coverage in this Quebec Science. I mean, it's a small world, I guess. There was a French correspondent from Canada who happened to be in Mumbai and who then kind of covered some of the aspects of our intervention in Mumbai. And so we had also done some, just preliminary research in terms of looking at the social structural conditions and impacts of COVID, and then particularly in this case, trans women in India, and how, while certainly everyone was affected, and India as like a middle-income country, there were a lot of challenges across the board. Very specific challenges for this population of, for example, not having the appropriate ID card because their presenting gender wasn't the same as that on their ID, and they hadn't been able to change it, so that they literally couldn't use the card to get food from food banks that were designed to help people who were living, below the poverty line in India. And so they weren't able to access that. There were some schemes in India, as well as certainly in Bangkok, where we had the project as well, that were providing some temporary social welfare that didn't really exist writ large in the country, but in response to COVID. But in order to apply, you had to have papers from your employer, showing that you'd lost your job or what your regular job was. And for some trans women, well, one, they lost, those that were in the mainstream workforce were often the first to go. And this is also true in Canada to an extent as well, in terms of sexual and gender minorities and racialized people who are precariously employed. And then when something happens, certainly of this major significance, they're often the first to lose their jobs, the first to be cut. But also the notion that, so some of these women, because, they had previously been engaged in sex work and some hadn't, but they had no choice because they had no wherewithal to earn a living. And of course, there's no way to show a card from your employer to get money and from government social welfare schemes based on being a sex worker. And very seriously about this, so they had very, very little kind of organized governmental support to be able to turn to. And so Safe Hands, Safe Hearts was born out of this multi-country kind of effort. And the main aspect behind Safe Hands was, of course, one, trying to create an intervention that was tailored for sexual and gender minorities, and in Canada, racialized sexual and gender minorities, but also from a basic understanding that even before COVID-19, that pandemic response planning most often is based on what we understand as mainstream society, and that it does not usually take into account the lived experience and also the existing vulnerabilities and strengths of various marginalized populations. So that failure to account for the needs of various marginalized groups obviously can seriously compound the challenges, because the pandemic response, while ostensibly geared towards supporting people and helping you to prevent your family and yourself from getting sick and knowing what to do if you did, are not designed with you in mind. And so that creates a lot of obstacles. So we used a theory-informed intervention. It was largely driven by motivational interviewing, which has enjoyed a lot of success in a lot of aspects of prevention, and it had been tested and used with various marginalized populations, including those who we were working with, so that it performed, it seemed like a good fit. And also informed by a psychoeducational approach, because some of what we were aiming at was to deal with reducing psychological distress. And so we had expertise on our team from different countries, and from understanding those perspectives as in theory and as practitioners to design the intervention. So that we worked on co-developing this in early 2021, late 2020. And so basically, just in a nutshell, the intervention was 3 online sessions of roughly 45 minutes to an hour each, every 2 weeks. There was a baseline survey before you started. People were screened in, and I won't speak to that, but there are, of course, a lot of challenges because the way that people understand various sexual and gender minority identities is really, really different across Indian, Thai, and Canadian cultures. And then also dealing with permutations of racialized cultures in Canada who might not adopt more mainstream perspectives. So we had rather open and porous ways to screen in, that people did not have to self-identify as gay or lesbian or transgender even, but they had, and we of course use different terms from the different countries. So you would have your 3 sessions if you screened in and you wish to participate, and then there was a 2-week follow-up survey and a 2-month after that survey. And so we've actually now collected most of the post-intervention data and some of the follow-up data. I'm not going to present this whole thing, but what I want to do is speak to some of the findings that I think are particularly interesting, and mapping on to some of what one might understand from a biosocial approach. One other thing, and I mean, this word is certainly bandied about a lot, but we were operating obviously in a pandemic, I mean, in which we're still, living and navigating. We started this before there were vaccines, frankly, so we didn't even aim for anything around mindsets and information about vaccination in the beginning because it wasn't on the map. And luckily, we had some flexibility to kind of engage with that as the intervention went forward. But it was really important, given the stressors, particularly that marginalized communities were facing in these different cities and country settings, that the intervention itself not be a source solely of stress and work. And so that we were trying to be quite mindful of, one, what's our purpose, was also supporting community-based organizations in their efforts to best serve their clientele amidst rolling lockdowns, for example, and also many new challenges that people were facing. And that those were somewhat different in the different sites, obviously. We also trained a lot of, so 16 is the number of counselors and interns trained in Toronto. Across the 3 countries, we trained 40 to 50 peer counselors and interns who delivered the intervention online, which was also helping to equip many of them working for CBOs, how to equip their staff in handling and dealing with the incredible challenges faced by their clients. So this was the first, screen that someone would see as they came to the project and move forward. So now I'm just going to very briefly just show you for the Toronto site. So this is the makeup of the population who engaged in the study in Toronto. By design, it reflects racialized populations. These are racialized LGBT populations who are often, existing on the intersections of multiple forms of, structural vulnerability. And so this was really in large part because of teaming with an organization that would probably not, understandably, be the kind of fulcrum for a project looking at LGBTQ plus, right? And so Women's Health in Women's Hands had the basis of a core clientele of Black women and women of color. And so we built out from there rather than going the other way, which is, of course, we did work with 519. We worked with other, many other sites around the city to try to recruit people and to get input. But rather than kind of working from a more traditional LGBTQ plus axis and seeing how we could branch out to Black people and people of color, we flipped it. And so we really, did quite well in terms of the diversity of our sample. Toronto actually became more of a pilot study because it literally took a year to get ethics approval to conduct the study through clinical ethics boards in Thailand, though we've now completed it, and India as well. And because of the rolling lockdowns, our target was higher than this. So it's the other sites are a little bit more equally distributed as planned between, broadly speaking, these three kind of subgroups, understanding, of course, many identities within this. But we wanted to look at potentially some gender-based analysis of potential differences. So this is just frequencies out of the baseline, but some of these numbers to me are like, well, I mean, astounding might be strong, but astounding in terms of, this was specifically asked, well, did you lose your job, but was it because of COVID-19? 44%, I mean, extraordinarily high. And then as you see, so these map directly on to various social determinants of health in terms of economic security, housing security, food insecurity, and then being able to support your family. And across the entire sample, decreased access to healthcare. These particular challenges in terms of access to services, so this is represented among people. So if you tried to get, among those who tried to get HIV testing, 29% reported decreased access due to COVID-19. But just shows really across the board some of the challenges in access to sexual and reproductive health services. And just one finding here, and I mean, this for me was very necessary to work with a women's organization. So, we don't only ask about condoms, that, they had various ways to look at then other reproductive health products, and that indeed the women's group had significantly decreased access compared to the gay men's group. And the trans group was a little bit small, so it wasn't significant. But across the board, very, very strong challenges in terms of access to genital healthcare, sexual and reproductive healthcare. And astounding to me rates reported of what would be screened in potentially as depression and anxiety. I mean, it's been written about in many, many publications, and this is like a worldwide phenomenon during COVID in terms of increases in serious increases in depression, anxiety, suicidality, loneliness. But these numbers really are just extraordinary. So just to cut to the chase in terms of some of our initial analyses based on the full sample of people who were engaged. Lo and behold, in Toronto, we found significant reductions in depression and anxiety. We did not find any significant increase in COVID-19 knowledge, so understanding the routes of transmission. And we also didn't find any significant increase in practicing hand washing, masking, physical distancing. Some of the challenges are that actually in Toronto, there were much higher rates of COVID knowledge. So there was really a ceiling effect. I mean, it was like very, very close to the top of the scale. And so, you know, potentially we could have asked more challenging questions, but it wasn't the issue in the communities we were working with in terms of knowledge. They got messages from Toronto Public Health, the newspapers and the like, some of which were, you know, authentic. And I'm open to see if people have interpretations of this, because I can spin something, but I wonder. So we didn't see a significant increase in these protective behaviors immediately post-intervention, but there was a significant increase 2 months follow-up. I mean, so I can't say that was not our intention. Our intention was in the post-intervention survey, but the data we're amassing from the follow-up survey so far is showing this, also this increase in practicing these protective behaviors. Of course, underlying this again was this motivational interviewing approach, not shaming people, not stigmatizing people around mask use or non-mask use, et cetera, and working within the structural conditions of their lives in terms of what was plausible for them to implement. But it certainly, we show these incredible positive results in terms of reducing psychological distress, which we initially thought actually that would be the most difficult thing to show a change in just a 3-session intervention. So I want to look at just briefly some of the covariates that we identified, because so it's not surprising, but so, you know, underlying greater depression scores was very strong influence of loneliness, reporting loneliness and social isolation. Now, I can't say this definitively based on our results, but it certainly, I think, can lead one to think about what might be the impacts of public health recommended measures, and including lockdowns, stay-at-home orders, closing of community centers. Understanding they thought they were trying to control the pandemic, but what might be the disproportionate impact on socially marginalized communities like LGBTQ plus people who may have somewhat different living arrangements on average than you know, heterosexual nuclear families. And not that all heterosexual people live in such constellations, but I would just suggest that there are probably more potentially fraught living situations to begin with, and that I think that we're seeing in part potentially a modifiable factor that may be engaged in terms of a pandemic response and planning. And talk about social determinants of health. So spun in the way it was analyzed here, that actually employment was the most powerful protective factor against depression, not losing your job. And I think that's understandable in terms of looking at all the stressors that we showed. So similarly, in terms of correlates of being really stressed out and intrusive thoughts about COVID and not being able to navigate it, emerging as a factor associated with anxiety. I think I have a couple of minutes and I'll just show, luckily right before the survey went live, we added these vaccine mistrust and conspiracy beliefs. And what we indeed found, and I just want to make this point, so that at this time, so the interventions started in roughly April of 2021. Vaccines were being introduced in Toronto, but they were not to all populations, and there were prioritizations of understandably older people, but not necessarily prioritization, well, not prioritization of marginalized communities. So 57% reported receiving at least one dose. And if you stop there and this is what I understand, unfortunately, about a lot of the discourse about vaccine hesitancy. Some studies now are kind of using that as a marker. So 43% are vaccine hesitant. Of course, the problem with that is you're missing the whole social ground in which this exists in terms of access to vaccines. Access, and are you getting it in a place that you would even want to go to because you're afraid of being stigmatized, treated poorly, some ways you've never gone before. You don't have transportation, you can't take time off from work. But when we ask people if you intended to get a vaccine, if it were offered to you, so of those 87 people who were unvaccinated, by and large, 80% of them said yes. And so it's just really important to kind of parse this, and that it's not merely receipt of a vaccine, obviously. If we want to look at potential hesitancy or mistrust, it's this very small group, certainly important, not this group. And so I think that some of our data shows that. And lastly, I'll just say that there was a very smart commentary written in Lancet Infectious Diseases, kind of looking at some of the contrasts in terms of that a COVID vaccine was developed like just a year after the virus was sequenced. 30 years later, of course, they're very different biological entities. We're still looking for an HIV vaccine, and there have only been 6 large-scale efficacy trials, many, many, many more smaller trials. And even these authors are talking about, of course, some of the more widespread urgencies to control COVID, and the investment of industry and the private sector because of whom we see COVID as potentially affecting everybody. Whereas this kind of skewed distribution in terms of HIV leaves us still in a place where there's not been similar support in terms of HIV vaccine development. But some of the lessons that haven't come forward, and we're seeing the outcomes of that all across the board now, and certainly in Canada, in the US, and many other countries, some of the incredible challenges around conspiracy theories, misinformation, not having dealt with issues of stakeholder engagement in terms of the clinical trials run and the development, so that you build, unfortunately, onto what some authors have called historically justified mistrust. This is not conspiracy theory. This is based on your history, your community's history. And that some of these, unfortunately, these same lessons that have plagued other vaccines, and that some of the work we've done for years, but unfortunately without a vaccine for HIV available, are emerging just incredibly and unfortunately now in terms of the distribution of vaccines, in terms of what some have called the vaccine apartheid, in terms of the lack of availability of vaccines, particularly in low-income countries, is just astounding. That in so the vaccine, basically, it says it's very low percentage, 3-5% in terms of low-income countries have even had 1 dose of a COVID vaccine, whereas many high-income countries, obviously up to 60, 70, 80%. And how, I mean, that is at the roots of obviously structural inequities writ large, I mean, well beyond Canada. So I'll just leave you with this, that thankfully our intervention did demonstrate some effectiveness in reducing psychological distress. We think we're seeing certainly some of the pandemic impacts on social determinants of health and pre-existing disparities among racialized, sexual, and gender minority populations. And also the hope that this is a replicable intervention because it's peer delivered, and we adapted it already for use in Mumbai, Bangkok, and Toronto, and that it could then be adapted for other other contexts moving forward. So that far from being great levelers, COVID-19, as HIV before it, are actually more underscoring the global inequalities in health. And that I would just make a pitch for this biosocial approach to really not just understand the social as an important context for interpreting biomedical phenomena, but actually flipping the switch, and that actually all biomedical phenomena must be understood through social structural conditions and historical conditions if we're going to be able to make an impact in a large way. I want to thank my collaborators at Women's Health, Notisha Masakroy, Wangari Thoreau, Luna Aiden, Joellen Forbes, and at U of T, Charmaine Williams, Carmen Logie, Sarah Sebastian, my colleague Adrian Butta at Windsor, our colleagues in India here and in Thailand, who really, made this intervention possible, that across the board, so roughly 800 people have completed this intervention across 3 countries. And we're moving forward now with exit interviews to understand people's reflections and understanding of what happened and what worked for them, what could be improved as we move forward with the intervention. So thank you very much for your attention. And I'll be very happy to welcome any questions.
Thank you, Peter. And to the participants, if you have any questions, please type them in the portal, and I will read them to Peter. I can see any questions you may type. I'll give you 1 minute to come out to start writing your questions. So, first question from Carmen. Peter, this is the question. What's your dream research project moving forward?
I'm sorry, what's my dream research project?
Moving forward, yes. It's from a participant.
Okay. Interesting question. Do you have a job? Do you have a job you're offering? Because I'm open to thinking about it. I guess my dream intervention is really for now, like frankly, part of running this psychosocial trial really gave me newfound appreciation for the insane amount of work that people running clinical trials of any sorts have to do, and the multiple layers of people involved in the trial. So I'm not sure I'd want to do this again, but given the tremendous input that has gone into this, and really the excitement and investment of the community agencies we've worked with in each of these places, I would love to see. It seems like now that this intervention, unfortunately, is still quite relevant, and particularly in middle-income countries, low-income countries, to move forward in further developing this and honing it for use for supporting sexual and gender minority communities and other marginalized communities amid a pandemic. And then looking at policy implications for how can we develop pandemic preparedness responses, and also in terms of seriously responding to HIV in a way that foregrounds these social conditions. So part of it I can cop to a little bit is it also depends on what I really valued in this project was the shared decision-making with these various community partners in different countries, which really shaped the intervention. And so that part is really what's exciting for me. So it's not even me coming in with a fully formed idea of what we're going to do. It's based on that collaboration. And that's really what gets my juices going is the collaboration aspect of it. So I hope that answers.
A participant wants you to expand on the slide on magic bullet. The slide on magic bullet. Could you expand a bit?
On magic bullet?
Yeah.
Okay, I'll try. Let's see. So really what I'm meaning with this slide, and I'm certainly not, I mean, I didn't coin this term, but what I'm meaning to represent is that in this, kind of modern age, postmodern age, there's this great reliance that we all have on technology, and including medicine, that it's going to solve all our problems. And we understand that there are challenges with computers and robots and, various technologies. But I think there's almost like this human condition, like there's some hope that technology is going to save us, and including a vaccine. And so that while, I'm very, very pro-vaccination and for people being able to have access and make an informed decision about a vaccine. But what I mean by this is there's no vaccine for racism. There's no vaccine for homophobia and transphobia. Like, there's no vaccine that is going to deal with stigma, and that's going to provide access, deal with the challenges in terms of, even within Canada, the geographic differences in access to a vaccine among different communities, and who's prioritized, who gets it first and why. So those messy problems kind of sometimes take the magic out of the bullet. And we're kind of very laser focused on this bright silver, lining thing that's going to save us. But it's these messy social, cultural, and structural challenges that are going to get us every time, to the extent that we don't invest heavily in terms of research, in terms of thinking, and in terms of approaches to dealing with different health conditions, and certainly pandemics. So I don't know if that gets it across, but that's what I mean.
Are there any more questions? Otherwise, so Peter, could you comment on how your views about how biological reductionism and neoliberalism will affect different groups with HIV differently, especially women, indigenous people? Did you hear me?
Can you repeat it? Sorry.
I said how your views about how biological reductionism and neoliberalism is going to affect different groups like women, Black people, indigenous people. How is it going to affect different groups differently?
I mean, on one hand, they of course affect all of us, but those communities that are subject and most violated by structural inequity, by systemic ideologies such as racism, are those who then are most negatively impacted by not looking at the social structural conditions that produce disease. Because the same challenges that created the problems and the inequities in the first place then impact on your access to the new ARV, the new drug available, to the new vaccine. And rightfully, you may need to communicate and have different forms of communication to build trust, because of histories in those communities of being violated by medical research in the name of the public good. So it's very understandable that people are not jumping out of their skin to be the first in line to try some new product. It's like, well, you didn't really care about me, 20 years ago. Why suddenly now are you so interested in my health and well-being that you're offering me this lovely vaccine? So, I mean, they're not unique to marginalized populations. Like, we all share in humanity in these challenges, but they disproportionately impact marginalized communities because of the ideologies behind disenfranchising people. When you then say, oh, well, it's an individual choice, take care of yourself, change how you, that's so lovely and easy to say when you don't have so many structural disadvantages. So, yeah.
We have 1 minute left. Somebody with a burning questions. Otherwise, This was very great, and we will thank Peter so much for such a great presentation. And clap your hands wherever you are. I'm getting a signal that our time is up. Yeah. All right. Thank you, Peter. That was.
Thank you, Dr. Lugan.
Yeah.
Much appreciated.
Okay. Yeah. Bye.